quick comment before we bring you all into this. There is another place that's been doing this for 30 years. It's called Hawaii. They basically adopted the Nixon plan. You're all familiar with the Nixon plan, right? What was the Nixon plan? All employers and employees, by government mandate, would have to contribute to health insurance in the workplace, and Medicaid would be expanded to include the rest. And Hawaii adopted that in 75. One of the curious things about the national debate is that nobody talks about Hawaii, you know, for better or for worse. I mean, it's a real-time experiment that's been going on for 30 years, and it really works quite well out there. But there we are. They just never were part of this debate. Okay, thoughts, questions, reactions? At least I see at least a few alumni of my health policy and politics class. I hope they've got a few thoughts here. Anyway, Barry, start off.
Sean, just two minor questions. You mentioned that in setting rates, zip code was one of the parameters.
It's an allowable, I want to make sure people understand when you use the word setting rates, when the carriers set their own rates, which they do in Massachusetts, zip code geography is an allowable rating factor because cost can vary. You know, health insurers are like gas station. I mean, 90% in Massachusetts, 88, 90% of the cost of goods sold is the price of oil at the barrelhead. It's the price of pharmaceuticals and doctors and hospitals.
But
it's not like so it's the cost of goods sold that really drives it. The cost of goods sold for healthcare varies between Springfield and Worcester and Boston.
And the second question I had is, in some of these plans you have a large deductible, a couple $1,000 you have to pay up front before the insurance kicks in. Are there any studies on what the impact is in terms of use? I mean, are there people who are not getting checkups who probably should be getting checkups because of that?
Well, you know, there's lots of studies, not of Massachusetts specifically, but the classic is a RAND experiment where they randomize people between different levels of cost sharing, and they found that there was significantly less utilization of services by folks who had more cost sharing at the point of service, and that the reduction in services was not clearly about needed services, it's sort of both needed and unneeded services. And there have been lots of ones that have replicated that with variations. And Medicaid in New Hampshire put on copays for drugs. People use fewer maintenance drugs, and so there was supposedly a bad impact on health and chronic conditions. So there's some controversy about it, but not very much about the idea that there's A, a lot of waste, and B, when you make people pay more for something, they use less of it, probably both the stuff they need and stuff they don't.
Hey, Amy.
Staying on the theme of, I'm Amy Wise, I'm just doing the Urban and Regional Policy Director's Project. And on the theme of insurance rate caps, I am curious if I'm actually separately working on another project now about the effect of healthcare reform on jobs. So I'm curious on healthcare jobs. Curious if either in the national or the state reform, if either of you or any of you have a thought on insurance caps or like changes in priorities that are coming along with the healthcare reform, like preventive care being emphasized, what effect that might have on healthcare related jobs, like hospital
On
jobs.
employment and the healthcare industry.
Employment, yeah.
Jim, you want to talk about that a little bit?
I'd say I don't really have any comment.
I specifically was thinking of like some of the layoffs that were happening at like UMass Memorial and Boston Medical Center, and they cited, Medicare, Medicaid, and things like that. So that was.
The only thing I have is, the folks I talk to in the medical community say.
You need to speak
Oh,
up
I'm sorry.
slowly
The
with
folks
that.
I talk to in the medical community say that nationally, the Great Recession has impacted demand for services. That both primary care, elective surgery, and a whole bunch of other utilization is down. That's a much stronger impact than anything I know about related to reform.
The recession and not so much the actual.
Yeah, the reform here and ensuring another 7% of our population primarily drove increased use of community health centers. I mean, and frankly, some increased use of emergency rooms, because that's where people who were, the uninsured are not concentrated in Wellesley and Weston, where they live by and large, and there resources for care are emergency rooms and health centers. And that's where they're used to going. Frankly, that's what's open at 8 o'clock at night as well. And so that's where the increased use is going.
Actually, Chris had it.
Go ahead, just want to follow up.
Just a quick follow-up on the emergency room utilization, because I think that is an important one, because it gets to when you do a reform, how sustainable is it? And I think the thing that surprised us is we expected emergency room utilization to go down. That people, as they got
That's because you're not an economist.
there you go. No, but as you subsidize insurance vehicles and people are insured, that they would actually find a medical home, right? But populations that were uninsured before are so accustomed to receiving care in one place that they don't really move. No amount of education has been able to move that needle. I know there have been lots of great efforts to do that, whether it be MC and other places, but it's really hard to do that. And to some extent, if you think about it, in the emergency room, no one likes going to the emergency room. But if you're a person who doesn't have, you've been uninsured historically, and that's what you're used to, and that's a place where you get really kind of full service care immediately, you're not going to go and say, well, now I'm going to call up somebody, I'm going to find a medical home, I'm going to go get the referral to go to this place or that place, especially when you may not have a car and all the rest. It's we've kind of created all these different stimuli that make this a really thorny, almost insoluble piece of how we redirect some of our resources. Because the idea behind the whole reform was that we're really unique in Massachusetts. We have the pot of somewhere on the order of $1 billion that went to institutions, to the hospitals, to pay for disadvantaged individuals. And we're going to redirect that, give them insurance, empower them to be individual customers, if you will, individual patients who buy their own care. And for some, we're finding they come in and get their care in the very same places. So it's something to think about in terms of how workable the reform is long term for that population, though I do lots of kudos on many other areas.
Of course, there is an issue of patient discipline here, folks, which we don't have much of in the United States. Most of these other national systems not only insist that you have a primary doctor, but you go there. And people do that. We haven't had that, and it's one of the reasons why people keep showing up at the emergency room, even though it's extremely expensive. Now, the new National Act doubles the amount of federal money going into community health centers. And in fact, in this state, we have, help me, 56 of them? Something like that. 52. And the whole point of this is to take the is to literally double the 20 million people that now use community health centers in the United States to make it 40 million. Interestingly enough, this is one aspect of the thing that has strong bipartisan support. George Bush was a big fan of community health centers. Orrin Hatch is a big fan of community health centers. And whatever else happens here, it probably, my sense is, it's going to turn out that an awful lot of Americans are going to get their health care at community health centers, beefed up by an extra $11 or $12 billion that in the new bill will be going to community health centers, some of which is already flowing to Massachusetts in the form of capital expansion and increased staff. And they're an important part of this thing. Now, whether or not, Jim, those folks that begin using community health centers on a regular basis can develop what I call patient discipline. I mean, that is so they don't keep showing up in the emergency room, because that does become their medical sense remains to be seen. But it's clear that in the new bill, with strong bipartisan support, this is one aspect of the thing that it seems to have very strong support of the Congress on both sides, and we'll see as it moves up here.
We have
Chris, I'm sorry.
No, I mean, actually, Jim's points, actually, and your points also lead into my question as, a lot of this discussion about healthcare focuses us on a really interesting question. I think for the students in the room especially, why doesn't healthcare work like a functioning market? Because that's the entire, in fact, the whole debate about the connector, the whole debate about how we structure healthcare approaches. Even if we put aside the legacy of history, going back to the IRS decision, healthcare as a market is an odd duck. And you comment a little bit about it, John, but would you amplify that a bit? Because why doesn't it work like an efficient market? Why don't we as consumers approach it like that? You made the point about cars. What is it about healthcare that is so difficult to function as a market?
Well, I'll take a shot at it because I think it's a really important question. Basically, in the 21st century in this country, we rejected any interventions that are not market-based. I would say that we are ideologically to the right of where we are. We're in the 18th century. And whether it's cap and trade, which is an outrageously inefficient market solution to just taxing carbon, or alternative to that, or it's this healthcare reform, which is very much a federalist program. It's highly decentralized to the states. It's market oriented. It's got Lincoln Chafee was the guy who actually first proposed it. John, sorry.
Lincoln's running for
Right,
governor.
you're right.
Right.
And I know,
You
Bill,
know,
I don't think
it's
you can
very, it's sort of very market oriented, and yet the conundrum is the market doesn't work very well. You know, even Jim's example of Japan and the $3,500. The reason they could tell him what I presume it's in Japan, that they could give him a price is that there's a government set fee schedule in Japan, so they know what the price is. If you walked into the Brigham, there's no way they could tell you the price ahead of time. They don't know what the price is, and the prices they use are not even relevant to what they get paid. So, you know, it's crazy. We've got this mindset that it has to be market, and I actually believe in markets. I'm not saying this because I'm particularly against government or a single payer or anything. But you know, I've lived 35 years in the healthcare markets, and they don't work very well. And part of the reason, and this is why I'm not an economist, but was an economic historian by training, is it has a lot to do with values. We have, you know, somebody once said, every system is perfectly designed to achieve the results that it produces. We have a system that reflects some of our values. So whether it be that Americans don't want to be disciplined into going to a primary care physician, they want to be able to doctor shop, or you know, they don't want government to play an overt role, only just subsidize and have somebody else do the discipline. You know, we had managed care working actually, I think, pretty darn well in this state in the early 1990s. We had like 1% and 2% rates of growth. And I'm going to tell you the secret, because I worked in a plan that was very successful at it. Had nothing to do with utilization management. It had nothing to do with that. That was all. We went from 500 days per thousand in commercial insured to 250 in the 1980s. What happened in the 1990s was we, the health plan, said to the hospitals who were the primary cost drivers, you shall not have any more money next year. That's your increase. And we had the market power on the health plan side to dictate that. So they all got together, right? They merged. We had an attorney general thought that was okay, that was great, because they saved people's lives. How do you do cost containment politically or in a market when that means taking money away from people who save lives for a living? There is nothing less desirable for a politician, and I can tell you insurers don't like it either, to do. It's really tough. So the value that we have, and we have employer-based insurance because we couldn't think of any other way in the American context to overcome the underwriting obstacles to getting people insured. And there aren't very many ways to do it. You know, the non-group insurance market is really tough unless everybody is born into it, i.e. government mandates it. Otherwise, you have this phenomenon of the sick getting it when they need it and the healthy not getting it. Group insurance is a way to do it. Why do we still have group insurance now? Because it costs $2.7 billion a year, and that's the only place we can get $1 billion a year to subsidize health insurance. Not because we like group insurance, it's because the employers have their money in the pot. So you start to build a system on value. You know, you don't go up against doctors. You don't, anybody who questions a doctor is a green eye shade accountant who can't, be in a position of saying no to a doctor. You don't do antitrust with hospitals because hospitals save lives for, that's their reason. They're good. Of course we want. Oh, they're going to coordinate care better. Yeah, you're only going to have one hospital left. That's fine. Be very coordinated. You set the price. So we have these decisions that get made. They reflect our societal values. And then we have folks who come along and say, no, this system stinks. We need single payer. Well, the United States is not going to do single payer. No, this system stinks. We need every individual buying on their own. Well, yeah, but where are you going to get $1.2 trillion? $1 trillion that the employers are now contributing instead? Through taxes? I don't think so. So we have, that's my answer, that we have taken, some smallish differences that distinguish the United States. That some are values, some are political institutions. We didn't have unions here with the strength in the 20s and 30s to be pushing a national health insurance. We weren't destroyed by World War II, so we didn't have to entirely rebuild our healthcare system from scratch like the British did, so why not have the government do it? these things, then they get magnified, and we are locked into America's biggest business. This is 18% of GDP. It is twice as big as manufacturing. It is 5 times bigger than transportation or construction. It is America's biggest business, and it is sclerotic. I mean, it's very hard to change. I mean, just look at this middle of the road ACA built on what Jim likes, Massachusetts, but as soon as Washington touches, oh my God, look what they're doing.
No. Wait a second. What you're doing is, again, you're applying, again, this goes back to culture and history. You're applying a system that works for us because of very specific institutions, such as $1 billion you could redirect to a certain cause.
Yeah, sure.
You've got already high insurance rates. Lots of very different things that make it unworkable in other parts of the country. Let me just say to your question, Chris, and I said I like part of it, not all of it. There are lots of things, as you know, that we'd like to change. Education and healthcare have so many similarities in terms of their resistance to markets and in terms of how sclerotic they are. And the thing that they have in common, and I love when John said, how do you do cost containment in a politicized atmosphere? Right. Well, you just said, what's the big problem here? The same thing in terms of cost of education. We see it skyrocket. The town of Rentham, the teachers wanted to have a 25% raise over 3 years. They got down to 14% over 3 years, not including step increases, and they decided that wasn't enough for them in this environment. And because they're not getting it, they decided not to write to write the recommendations for kids who are graduating, not spending any extra time. Those are the sorts of things that John Silver, when he was running the Chelsea school system, used to say, if you cannot take a strike, you don't control the system. That is, if you allow the adults in the system who are accreted interest over time, whether the hospitals that frankly overcharge in many instances, and in the case of, say, BMC, serve incredibly hard to serve populations, it's a very different challenges for different institutions. Somehow that's really unfair, right? And everybody's cut their deal. If you go out to Bay State Medical in Springfield, they got their deal across the border with Connecticut. And if you look at the folks in the Southeastern region, South Shore Hospital, they've got their own deal. Everybody's got their little behind. It's all sclerotic, but because there are all these veins running around and kind of twisting and choking us off, frankly. The charter school example is a good one. And it does go directly to what you're saying about the HMO system in the 1990s. That is, I hear so many people talking about capitation again. Accountable care organizations.
Global payments.
I mean, they're all talking about.
We've seen this movie before.
We've seen this movie before, but what I'd say is this: look.
And it worked for a while.
It worked for a while, and in fact, it's the limits. That's where you bump up against the values discussion you have. The limits of the network.
Didn't like it.
Didn't like it. Right. If you take a look at
a lot of us liked it. It was terrific.
If you take a look at the voucher versus charter discussion in education, which many of you are familiar with, there's an applicability here. The wild-eyed and woolly view of markets is, oh gosh, let's give everybody a voucher. It doesn't work that well, at least to date, in education. It's worked better in terms of safety. The outcomes are somewhat better, but not in the terms of excellence that we expect for kids. Not like the charter school movement here in Massachusetts. The charter school movement in Arizona, there are 600 of them, they're not very good. The charter schools in Massachusetts, there are about 70 of them, and they're really good. 90% of them are better than the district schools. 30% are off the charts better. 30% are a lot better. It's about policy, right? No one's arguing against policy, but what do charters do? They incentivize individuals to make choices. They buy into a specific ethos. An accountable care organization will say, we want you to do specific things to take care of your health, to participate in that sort of thing. There's a capitation. They get a per pupil amount, which is the equivalent to the district. And that's a market mechanism that allows people to have the right incentives to move forward. That's the kind of market mechanism that has an accountability system in place. And frankly, it needs lots of good information. And one of the things we've fallen down, we haven't talked about at all, is all that hidden information about cost and quality. And then frankly, I don't buy any of the arguments that it can't be done. It can be done very, very easily. And where it cannot be done, so that I, Jim Stergios, can read through it because I'm not the expert in this. In every other industry, whether cars or other things, like there are intermediary institutions, whether Consumer Reports, other folks, who'll go through and tell you what's underneath the motor inside the computers of a Toyota. I don't need to know that stuff. So I mean, markets can work in here, but you do need some government structure. No one would argue that if we want to, fulfill our full values and have excellent health care. I mean, just basic coverage, but excellent health care that meets the needs of folks. But you also have to engage them in that election process. I want that. Otherwise, you're going to get people to keep going to the emergency room. And over time, you can crack that nut, I think.
I'm going to suggest one other thing that's a problem here, because actually I think Jim and I agree. I mean, we're both sort of rebels. We both sort of don't like the status quo. We both think it's some rip-offs, you know, there's just a lot of deals and so forth. And yet we come out a little bit different politically, and that's one of the things I noticed about healthcare. It becomes philosophical and ideological very quickly. It's sort of like the cost containment question. I don't really understand it fully why it happens. For example, the Utah-Massachusetts thing that you were talking about, we're actually not very far apart. We're actually pretty close. There's been a lot of, I think maybe unconscious, mistaken exaggeration of the differences in order to draw a left and right contrast between two slightly different flavors of the same market mechanism. And it's interesting, and I go around the country, and people love that dichotomy. We have every health plan that wants to be in Commonwealth Care is in Commonwealth Care. We have not kicked any health plan out of Commonwealth Care. Every health plan that wants to be in Commonwealth Choice is in Commonwealth Choice. We have not kicked any health plan out of Commonwealth Choice. There are 9 different benefits products in Commonwealth Choice, so there are 60 different ones in Utah. You can argue about is that helpful or not helpful. You know, in Utah they only have 3.5 carriers. I mean, that's the entire market. We actually use the connector to bring a whole new carrier. The first one in Massachusetts in 30 years. We used it we used in market incentives to disrupt the status quo, to get new competition. Why doesn't the Wall Street Journal love that? Why don't they love it? There is this tendency to take the smallest difference and blow it up into some ideological divide. And I just, more so in healthcare than anywhere else, I don't know why.
See difference.
I don't want to. I don't want to preempt any time, except to suggest that there were some major policy decisions made in the early '90s in this state that had a profound effect on all of this, better or for worse. We treated hospitals as public utilities in this state until the early '90s, and we decided we were going to get rid of the Rate Setting Commission. Now, the Rate Setting Commission was an interesting institution, quite contentious, no question about it, but we decided to get rid of it. And then somebody, at about the same time, decided it was okay for the Brigham and the Mass General to merge. Now, there wasn't the slightest healthcare reason for that merger, folks. You don't merge a 700-bed hospital, a 1,000-bed hospital, and get any efficiency out of that. Quite the contrary. Now, those were 2 policy decisions that were made. I don't want to tell you who the Secretary of Health and Human Services, who the governor was, but they've had a profound effect on it.
And was our founding executive director, by the way.
Right.
Or who the Attorney General was.
Who the Attorney General was, who was a good friend of mine, but I think made a serious mistake going along with this stuff. Final point, I just now want to flip it over we'll go to Peter and then Barry. This is a highly regulated system from a quality standpoint, and nobody would have it otherwise. I mean, there is not free entry into the healthcare marketplace in terms of providers. I mean, if you're a doctor, you got to get a license. And if you're a hospital, you're licensed. And people wouldn't have it any other way. I mean, they want that side of it regulated. So I think, John, that may be another reason why talking about markets in any traditional sense doesn't make any sense, because barbers no longer do surgery these days. You know? I mean, it's a pretty restricted place with restricted institutions, restricted providers, and that, I think, creates a somewhat different atmosphere. That's the last editorial comment from your moderator. Peter.
I mean, this may be a simplistic view of it, but at least to me, it looks like the 2 primary ways in which the Massachusetts reform interfered with free markets were, 1, prohibiting insurers from using health conditions as a basis for eligibility and ratings, and 2, from the insured point of view, the requirement of insurance. And I'm curious, Jim, in your comments, you had a lot of criticisms of specific things. You didn't comment on either of those, and I'm just wondering, are those things about which there's consensus that, our kind of system, you need to intrude on the market that deeply?
It's a great question. Peter. I think on the former, I would say that's probably a done deal. I don't see how those prohibitions on healthcare insurers go away, frankly. I think that.
You're talking about the universal coverage?
No, not talking about the
Pre-existing condition.
Pre-existing
Yeah,
conditions,
I think-
but that preceded healthcare reform by 10 years or so,
Correct.
right?
Correct. That's what I'm saying. I didn't see how that was going to get peeled back, whether through that reform or otherwise. The mandate is a very interesting question, and I think there are ways that we would have preferred to see something akin to a mandate move forward rather than the way in which it was done. I think the early, and John, you can actually correct me on this if I'm wrong about this. I was actually doing environmental regulation at the time, so I wasn't privy to all that sort of stuff. But the original idea that came out of the Tim Murphy, who was Health and Human Services Secretary, and Governor Romney at the time was they wanted each person, each individual, to have some sort of it was $10,000 bond that they would put up in case they had to go to the emergency room and the care cost more than that they would have to carry something like that. Still a mandate.
So can I comment on
yeah,
that?
please.
Because I think that A, that's right, and they didn't get that. But B, it illustrates I believe it illustrates my point about our tendency to ideologically stratify things. What they proposed, and I've talked to Tim about this, is they said you either have to have insurance, or you could post a $10,000 sort of bond or whatever, so you can at least pay for the first 2 minutes if possible. And that gave it an acceptable patina to the right half of the political spectrum, that they weren't mandating insurance, they were just mandating responsibility. You could cover it however you want, you just have to be accountable for your insurance. There wouldn't have been more than, I mean, it's all speculation, but I bet my firstborn there wouldn't have been more than 10,000 people out of 6 million in Massachusetts who would have opted to put up a $10,000 bond instead. But it had that little, it was acceptable, and it was something that, Romney, when he ran for president, could have said, no, I didn't mandate insurance. So it's sort of a gymnastic charade. That's too strong. It's a fig leaf. It's a fig leaf to say.
I like gymnastic charades.
To say that it's not mandating insurance. For all intents and purposes, it would have been mandating insurance for the vast bulk of the population. And what do we have? So what's the difference? And yet, I think you picked up on it, and not because you picked up on it alone, but because the Republicans, Romney and Tim, they really emphasize this. But is it really that important? And it's sort of this ideological thing. We really don't want government to organize the sector, even though, as Michael says, 50% of the financing is from government. Government is often as not trying to untwist some of these, incredible insider deals. Maybe government isn't an efficient way to do it. It's hard to imagine it's going to be done without government intervention. Even deregulating requires a consensus and joint government action. So you're kind of stuck with this government involvement one way or another.
I don't disagree. I guess the thing is, the reason why everyone, and it is kind of ridiculous to see all the gymnastic charade, as you put it, is that both sides, we're adults who are not having a real adult conversation where, the number of uninsured, the percentage of people uninsured is artificially bloated on the basis of people actually between jobs and that sort of thing. But there's always these talking points out there. And I think, look, I do think that mandates, this is Massachusetts, a mandate, this is the third try for Massachusetts on universal care. And I think that you get people more and more used to the idea, and it's an easier sell to get done, plus all the historical and sort of the particularities about our budget situation, how we budget for healthcare and the population, made it possible here. I've got to tell you, that mandate is not going to fly in so many other parts of the country. It's just not going to be implemented well, and the federal government's never good at implementation. I don't care what anybody says, they're never good at implementation. It's going to take states working hand in hand with them, and there are a lot of governors after this election that are really not going to work very hard with them. So I think the mandate question is definitely on the table. My preference, frankly, is not to have one. I understand what that means. My preference is to work on many other fixes within the context of an exchange to lower rates, to make things affordable, whether on the mandate front, whether it's, there's so many people who work part-time. Take a look at the population in Utah. There's a ton of part-timers there. So for them, what they want to do, and there are lots of part-timers here, frankly, because no one wants to hire a full-time person because of the cost of healthcare. It allows, if you have 2 part-time jobs, you can aggregate what the employer provides on this side with what the provider provides on this side, and you can use both together to aggregate that and actually make a purchase of healthcare. There are lots and lots and lots of different things. There are probably 10 different things you could do to kind of correct things, but before we get to mandate things, that would be our approach, frankly.
Barry, one last comment, I'm going to wrap up.
It's a comment and a question. I want to pick up on Chris's important issue about why doesn't the market really work in healthcare. And I want to go back to my teaching years ago. I don't know a lot about healthcare, but I used to teach Milton Friedman because I am a great admirer of Friedman, very conservative kind. But his argument was, when it came to healthcare, I remember being in a was that in most markets, you have two sides of the market. You have the demand side and you have the supply side, right? That's what makes a market. And that generally in most markets, the people who are on the demand side and the people who are on the supply side are different people. So you have somebody trying to demand, somebody trying to supply. But in healthcare, it's really muddy because when I'm ill or a family member is ill, I go to a doctor and the doctor basically tells me what I should demand. Right? The doctor's going to supply the care or the health. I'm in Harvard Health, an HMO. They're going to supply the care, but they're also telling me what demand I need. I need this test, I need that, I need this, I need that. Now, Jim got to the point where he was basically saying, well, we need more information in the system so that I could be an independent demander. But I think when it comes to healthcare, it is really hard. Even if I had a special consumer reports which said, you know, look, you've got a malignancy, da-da-da-da-da. My answer to my doctor is, I want to go see the best guy on prostate cancer, period, right? Who is it? Who's the best doc on that? And I think that's the fundamental problem, and I'm not sure there's an easy answer to the market failure of information.
I don't disagree. There's never an easy answer in this thorny neck of the woods. But again, I'd go back to education. Education is the very same thing. The very same thing is at work. Look, I want the very, very best for my kids. All right, you do too. Everybody in this room will want, you don't have kids yet, I'm sure do. You're going to want the best thing for your kids, right? There's no elasticity there, right? I want the very best, and I'll make sacrifices. And everybody, I don't care what anybody says, at the lowest level economically to the very top level wants that. And that's where structured choice, and this is what I was talking about before, where you do have good information about what works and what doesn't. That's the beauty of the MCAS, whatever its limits are. You can see what charter schools work and which ones don't. You can see what districts work, which ones don't, which schools within the districts work, which ones don't. And it applies a level of pressure in order to have people come to you and want to use them. That you're setting up the incentives right. What makes the market not work is that the incentives are absolutely incorrect. They're not incentives on the individual purchaser. They don't have the correct information to work from. And even within that, the market's not going to work perfectly. It needs to work to 90%. And you're going to need to have real intervention on the part of the government to take care of the folks who aren't able to use that system directly, is my view. And one of the things that one of my problems with this larger health fix, which goes up to 400% of the federal poverty rate, is we lose focus on the people in the lowest rungs as well. We start ensuring everybody, all the political decisions are about politics, about the next electoral cycle, and it's not going to be about the folks in the bottom 10% who frankly are not going to be able to get the right kind of health care. And we lose focus when we lose focus.
I'm sure we aren't taking good care of the folks in the bottom 10%. It's the folks in the next 10, 20, 30 that have a problem. I mean, if you're in the bottom 10%, you get Medicaid. It's pretty good health care.
So to throw in a more optimistic note, I think there are 100 reasons why the market doesn't work very well. But we actually do pretty incredible stuff in medical care in this country in the 21st century. And it's part of the problem, as Jim said. It's such a desirable good. And it's quite clear around the world that the more money a society has, the more of it, not just arithmetically, but the greater percentage of it that they dedicate to healthcare. And it's also true in the United States among states in general. So that's part of that values issue, that we actually love consuming healthcare. I mean, we don't, as individual patients necessarily, but we think it's a pretty good thing to do. And if you look at our economy in Massachusetts, the rebound from the recession, the resiliency is built largely on education and healthcare, because they are socially desirable goods, and boy, are they resistant to recessions. They have such built-in isolation, right, from normal economic forces. How do you know a good university? They're the ones who charge the biggest tuition. You know, and so there are these, and there's 101 reasons like that, values and structure, that tend to defeat the market.
Well, on that note, you're all receiving a tuition increase next week.
No, we are getting good care.
A couple of ending comments. First, a special thank you to these two guys who I think deserve a round of applause. Secondly, may I say on the education front that as somebody who graduated from high school at a time when over half the kids in this country and half the kids in Massachusetts never finished high school, we have made some significant progress. I mean, a lot of it. And finally, just a historical note, workers' compensation, a mandated form of insurance, began in the Commonwealth in 1908. I think I'm correct in saying, Barry, check me if I'm wrong, that 49 states require employers to provide workers' compensation. The one that doesn't is the state of Texas. I mean, there's just something about that place.
They are also
You're not voting for office, I can
they're
tell.
also growing very fast. And their budget problems aren't nearly as bad as ours.
Anyway, thanks to both of you, and Donnie, thanks to you, and everybody who helped put this
Chris, do you
together.
want to mention about tomorrow night's open classroom?
Oh, you just did, Barry. Why don't you go ahead?
Tomorrow night in the open classroom,
I'm gonna be there. Yeah.
we're going to continue this conversation about policy advice to the governor, the healthcare sector. So we're going to continue this. We have the new CEO of Blue Cross Blue Shield and one of the leading experts at the Harvard Public Health School. We'll continue this discussion 6 to 8 o'clock tomorrow evening, West Village F, room 20. What?
West Village 20.
West Village
Yeah.
room 20. West Village F. Terrific. Everybody's invited. Come enjoy.
Thank you all very
Thank you
much.
guys.